Hi, Ro. I'm so excited that you've come to join us. Tell me about your journey so far.
One of the things that I've noticed with dry eye is 20 years ago, if I were going to say, hey, we're going to have a dry eye meeting, or we're going to have a conference on dry eye, or we're going to have a lecture on dry eye, everybody would put their head down and then start walking away. And what's happened over the last few years is we've had a renaissance. And why do I call it a renaissance? Is because it's a new way of thinking of the disease and coming up with new ways of treating it with that new philosophy. And then when you came to me a couple of years ago and you said you had this idea, it's always been in my head to have just dedicated dry eye clinics. So I think we were very one with in spirit.
Yeah.
And when I met you and Andy, at first I was like, oh, these people are just as crazy as me to think they can have a purely dry eye clinic. But then, now you were fast forward 2 years and it's not one clinic, it's several clinics. I've kind of done the same thing in New York City. And when I opened that one in New York City, it was like just a dedicated dry eye clinic. I mean, are you even going to have any patients? And as you've seen here, the first day we opened up the doors, you have tons of patients because this is a major problem. And now people are waking up to how big of a problem it is. You go to China, it's 60% of people have dry eye disease. United States, 20%. Looks like it's basically the same here. And if you build it, they will come, and that's exactly what's happened. So, and there's people who are pushing the boundaries, and I think what we've done here in Australia is just that. And now what the hope is that we raise the level of treatment, and either the other doctors will go with that paradigm shift and raise their level and change their philosophy of treatment, or they will continue to lose patients, and patients will seek out better treatments. And that's what you learn, is that patients with this problem are suffering, and they will do anything that they can to relieve that suffering, and they will seek out clinics that will help them. So this is great. I mean, this actually, it took over 20 years to get to this point, but I'm just so happy that we've gotten this point and we've been able to treat and help so many patients. And that's what I always keep in the back of my mind, is that we're actually saving lives, and it is saving lives, because patients have told me, you know, before dry eye my life was one way, and then after dry eye my life was completely different, and I couldn't live my life in this way. And now that I found these clinics, I've been able to function normally and have a normal life again.
So with your philosophy on dry eye, obviously in Dry Eye Solution we follow the Toyos protocols, or you've instilled it in the business. Can you talk a little bit more about what the Toyos protocols are and what we're doing?
Yeah, so what I was taught when I was a resident and a medical student was dry eye is a fluid problem, that it's just not enough lubrication. And if you think of it just as a fluid problem, oh, we just have to lubricate, that doesn't solve the problem. So what IPL did for me is, when I started doing intense pulse light for patients on the aesthetic side and for rosacea, and I saw that it helped their dry eye, I started thinking of dry eye in a completely different way. And the way I think of it, and this is the philosophical change and this is the paradigm shift, is that this is a skin gland problem that creates an abnormal inflammatory tear, and that inflammatory tear actually destroys the ocular surface and causes all the problems that patients suffer, which is pain, inflammation, irritation, poor vision, and all of it. So once you have that philosophical change, then you start thinking of treating patients in a completely different way. You start thinking, I've got to improve their skin, I've got to improve their glands, and if you're thinking that way, then now you have to treat them in a holistic way, because just putting more lubrication on their eye is not good for their glands and their skin.
And it's not working.
And it's not working. And it's just washing away even the natural products that our tear is making, which is 2,000. Now we know there's 2,000 products that our natural tear is producing to help keep the eye functioning normally and to help us feel well with every time we're blinking. So if you want to improve the skin, anybody that deals with skin knows that, okay, if I want to improve the skin, diet is important. The medications I'm taking can affect my skin. The way I treat my skin is important. The products I'm putting on my skin, my environment. So, one of the things, like my mother suffered a mold problem, and she kept complaining to her doctors about this mold problem, and they didn't believe her. They didn't believe that it was affecting her in the way it was affecting her. Even where she was living, they're saying, oh, we don't have a mold problem, but then it was discovered it was a mold problem, and then they discovered that mold can affect your immune system and can affect you systemically and can affect your skin and can. So that's what I think here, is that even your environment plays a role. So one of the first questions I ask patients is, have you moved, or have you changed jobs? Are you in a new environment? Are you doing something different? So instead of just thinking, okay, I'm going to put more lubrication or more artificial tears on this eye, you start thinking about everything. So you get back to Hippocrates, and where he said, the whole of the patient is what you should be thinking about and not the disease. So that's the philosophical change, is that now you're thinking about so many other things. People's immune system. Like one of the things that I saw with COVID and the COVID vaccine, it really affected a lot of people's immune system, where it changed their own natural immunity to the point that it started affecting their eyes in all sorts of different ways. So now you're thinking about, what medicines are you taking? What's your environment? What's your food? What are you putting on your skin? What are you allergic to? What are you not allergic to? Everything. And that takes a special type of doctor, because most people, when they see patients, is they want to go straight to the disease and fix it. I'm a surgeon. A patient comes in with cataract, and I'm thinking, you have a cataract, what we're going to do is we're going to take out this cloudy lens, give you a new lens, and you're going to see better. That's a 2-minute conversation. A dry eye patient, if you're going to be treating them in a holistic manner, you're going to have to find out everything about them. So, you know the philosophy. You learn so much about your patients that you become really bonded to them, because you know their whole life. And that's the only way that you're going to be able to treat this problem, because you have to know all those things to be able to make the changes for them to improve the skin, and then improve the skin, the glands improve, and then their tear improves. And then you have to change your philosophy on medications. Like, some medications are good, some medications are bad, but now you have to prioritize which medications they need, but which medications maybe we can change so that their whatever other health problem they have won't affect their eyes. And so we were talking about this earlier. The way we were taught is, somebody had dry eye, the thing you were going to do for them is artificial tears, warm compresses, and doxycycline. I have a lecture where I say, the 5 things you're doing wrong in your dry eye clinic, and those are the top 3, right? Because doxycycline kills your good gut bacteria. You kill your good gut bacteria, then you're going to have an immunological inflammatory rush. They call it a cytotoxic storm. So you don't want to give doxycycline for a dry eye patient, because you may win a small battle of decreasing their inflammation in a short period of time, but in the long run, you're causing more inflammation, which will cause the glands not to work. Warm compresses. So what warm compresses do is they actually create more inflammation in those abnormal telangiectasias on the epidermis of the skin. So heat is not good for patients with dry eye, especially patients with rosacea, because it's just going to cause more inflammation. And then artificial tears. Artificial tears could have products in them like BAK or boric acid, things that are going to destroy the ocular surface. It washes away your natural tear, washes away all those elements that are decreasing blepharitis, decreasing bacteria on the lid margin, all these different things. So all those are wrong. And the other thing is people give an artificial tear and they tell a patient, oh, take this. Well, a patient doesn't know, you're not telling them it's like a medicine, take it once a day, twice a day. You're just handing them this thing and they're going home and they're using it 5 times a day, 6 times a day, 10 times a day, destroying their ocular surface, washing away their natural tear. So philosophically, what we're doing is completely different than what we've been taught.
Yes. I love that we're doing it this way. I find that a lot of patients that come to us, they've seen quite a few people, but one of the philosophies, or what you taught me, and I understood anyway, is that patients really need to be heard and listened to, but in dry eye more than anything else in optometry. So it's a very cathartic process for them to be listened and understood and asked all the right questions.
Yeah, I mean, the first chapter in my book is patients come in and they want to tell you their story. Yeah. Like, when was the day that dry eye pushed them over the edge? And I tell about my story. I have dry eye, so that's one of the reasons, I can empathize with my patients, because I have a story of when dry eye affected me so bad that it affected my work and what I was trying to do. So they want to tell that story, and you have to let them tell that story so you can understand them and where they're coming from. And dry eye didn't happen that one day, but it was a whole years, and it built up to that one moment when it really affected them.
So you've got your Toyos Dry Eye Diet book, which we are launching in Australia next year, early 2025. So do you want to talk a little bit about that, and what are the main messages in that book?
So the diet book I worked on for 3 years. Yeah. And how did I come to writing a dry eye diet book? So I'd always talk to patients about their diet. And I would tell them, look, these are the things that you shouldn't eat. These are the things you should eat. But it really wasn't hitting the target. What patients want is specifics. Okay, what shouldn't I eat? What should I eat? How should I eat it? When should I eat it?
And how much should I eat it?
How much should I eat it, and why? And that's a totally different conversation. It's a long conversation. So, one of the things that I tell patients is I've been working on my own diet, and personally, since I was 7 years old. I had a father who was an ex-professional athlete, so everything that we would eat would be, okay, you're eating this because of this, and you're going to grow up strong, and don't eat that, and put down that Twinkie, put down the Oreo cookie, So diet has always kind of been central in my mind, so I've always kind of done the research. But what I found doing the research for this book is that there's a lot of stuff that we're not told, that there's really no drug companies that are sponsoring big conferences on what to eat and how it's affecting your health and wellness. But the information is out there. So I have 300 references, PubMed referenced research articles in this book. And so what I used to do for patients, this is how it all kind of started. I realized that gut health was very important in terms of, if I can improve their gut health, I could decrease their inflammation, which would help their skin, which would help their glands, which would help their dry eye. So I would actually, one of the things that I would do is I would have patients give stool samples. So send it in, and then we would look at their gut health. And what I found, 100% of my dry eye patients had terrible gut health. Their bacteria in their gut was bad. And they had a decrease in the good gut bacteria that decreases inflammation. So once I found that out, then I had to start working on a diet that would actually change their gut bacteria and improve their gut health. So then I started working on diets, and I started doing research on prebiotic and probiotics. And one of the first things you realize is that a probiotic pill thrown into an acidic gut is just a waste of money.
Yeah.
It's not going to change your gut health. So you actually have to change your diet. So I have a 2-month starter diet that I tried on patients, and I told them, eat this. These are the only foods you can eat, and you can't eat anything else but these foods for these 2 months. And lo and behold, we would do the stool samples, and their acidic gut would turn into a healthy gut. And they were feeling better, and their eyes were feeling better, and their dry eye was better. And then using that information along with the studies and along with looking at the blue zones, so we have people in the world that live longer, healthier, have lower rates of dry eye, and have really healthy guts. And you can look at all these things, put them all together, and figure out what is the dry eye diet. And the dry eye diet might be different than what a patient that doesn't have dry eye. So most doctors recommend a Mediterranean diet for their dry eye patients, but a Mediterranean diet actually is not good for the dry eye patient. So there's foods that are inflammatory to the dry eye patient: dairy, eggs, meat, poultry. So we want to eliminate those foods, and then we want to eat foods that are going to help our gut maintain the lining so that bacteria can't get through and cause an immune reaction in the body. And then what we've learned from the blue zones is, 90% of the stuff that you can eat is great for you. But if you have certain times in, the year that special occasion and you want to eat that certain food, the birthday cake, whatever. So you do a 90-10. So you do a 2-month very strict diet, change your gut bacteria, and then you can go to a 90-10 diet. And so what I have in the book is what foods to eat, why you're eating them, and I'm a glass half full type person. They've studied this. How many times have you met somebody who had a heart attack? They have an epiphany, and then they change their whole lifestyle and whatever. And then they're healthier, and they're stronger, and all that. So I tell my dry eye patients, so you could look at this disease as a burden, but you could also look at it as a blessing, because this is your heart attack moment. It's caused you to change your life in a very positive way. So I have patients now that have been my patients for over 20 years, and they tell me all the same thing. I'm so much healthier. My skin is so much better. I look so much younger than slimmer. All these things. I feel better. My dry eye is better. All these things. So glass half full is this disease pushed you to the point of changing your lifestyle. And even to the fact of figuring out that their environment was making them unhealthy. I talk about wellness buildings and how to make your surroundings healthier for you.
Like you did with here when we were...
That's right.
Yeah.
And which I'm doing in all the clinics. So I'm leaving clinics that I find are unhealthy, and over the years I'm designing our clinics to be healthier for my workers, so that they come into an environment that is not unhealthy. And we know this information now. We should be using this information. So patients, I've had patients who have said, yeah, my work environment was killing me. And I go, well, what are you going to do about that? And they've changed jobs, or they've made the employers think differently to make the environment healthier. They've changed their home environments. They've changed the way they work. Nowadays, one of the biggest problems with the dry eye patient is their work environment is putting them and their eyes at risk, because they're sitting there staring at a screen all day and not blinking as much as they should be. So that's in the book, like how to change your environment, how to change your work life, how to change your home life so that you're healthier. So I really believe that this book is about dry eye and helping your dry eye, but I also think it's, in my trilogy of health and wellness, because I've written other books on kind of health and wellness, but I really do think this is like that final book that brings it all together. and that I'm hoping, 20 years from now, people will go, I started this lifestyle and it helped my dry eye, but not only helped my dry eye, it helped me live a longer and healthier life. Because we all want to live longer, but we only want to live longer if we're healthy. And that's what you see in the blue zones. I talk about this in the book. I was in Japan, I'd given a lecture, and I was eating breakfast, and I was looking out the window, and there was like 40 older people in this park. And when I say older, they were 85 and older. And they were talking and laughing and like stretching and doing a lot. I'm like, wait a second, what's going on? I go out there and I go, what is this? And they go, oh, well, we meet every morning and we stretch out, and then we find out about each other's lives, and then we go for a walk, and we do this every morning, and this is their ritual. And like, this is part of it too. Changing your life to socialize. Yeah, and that's, actually the dry eye people have created their own communities to support each other. And it's funny when I walk into the clinic and I see my dry eye patients talking to each other, and they've talked to each other on the internet for years, and then they finally see each other in the clinic, and they're like old friends. Yeah. So, but that's part of it too. That's part of the book too, is like teaching you the importance of your social interactions, and these are things that people are doing around the world, and it's helping them live longer.
So with the book, is it a book that you would recommend for patients and optometrists as well?
Yeah, because 95% of the stuff that eye doctors are taught when it comes to dry eye is wrong. Yeah. So I think it's a good book to reset their mind, open their mind. Yeah. One of the things I talk about in the book is that the medical profession is one of the worst professions in terms of adopting paradigm shifts. So in medicine, a great idea that actually works takes 17 years to actually get into the textbooks and be taught. And be taught as a way of, this is the way you should treat patients. So this is why it's so difficult to get doctors away from the warm compresses, lid scrubs, artificial tears, and doxycycline, is because it's ingrained in their brain. This is what they read in the textbooks, and it's really hard to kind of change it. So I really do think most doctors, they probably don't know any of this information. Again, it's not, I think we got 2 days of nutrition in medical school. Nobody talks about that. So I think this is a good way to kind of reset the brain and look. And like I said, I don't reference anything in the book unless it had published research to go behind it. And if it didn't, I say, this is a philosophy, and this is where this philosophy is coming from, and you should continue to look at this in the future and see if this is actually something you should adopt. But definitely doctors should read it.
Should read it. So I know it's going to be available through Dry Eye Solution next year through our website, but where is it available right now? I know it's on Amazon. There are some.
It's on Amazon. One of the complaints that I had from a lot of my dry eye patients is like, I can't keep my eyes open to read a book. Yes. Can you do it on audio? Yes. Yeah. So it's on audio, so you can go to bookbaby.com and get the audio version. It's not my voice, but
shame.
I know. I had a choice with AI. You can pick an Australian voice or
G'day.
G'day. Wouldn't that have been great?
Yeah.
So we actually picked a voice that kind of sounded like me. So.
Okay. What are the risks and the long-term consequences of somebody who has dry eye disease and it's not picked up until it's at the very severe stages, which we're seeing a lot of? Yeah,
so I thought, in theory, I thought to myself, this is an inflammatory disease, and if you don't do anything about it, that inflammation over time will cause ocular surface damage and damage to the conjunctiva, to the cornea, to the lid margin, to the skin, all of it. Then, about 2.5 years ago, our clinic bought confocal microscopy. So confocal microscopy, you can actually see the microscopic changes that are going on in the cornea in patients with dry eye disease. And when I first got it, I looked at confocal microscopy of normal patients, then mild dry eye patients, moderate dry eye patients, and severe dry eye patients. And I was astonished to see even patients who were very young with mild dry eye disease, it was actually destroying a lot of the structures of the cornea, like the nerves. You could see the inflammatory cells in this cornea, and that sealed the deal with me, is that we're not being aggressive enough in patients with really mild disease or asymptomatic disease, is that we actually have to get in there and start treating them right away, because what's going to happen is, this is why they're having a moment like 10 years later, but this disease has been going on for 10 years, is that it finally gets to the point that that inflammation has done so much destruction to the glands and so much destruction to the eye that they have to do something drastic to bring them back. So we have to see this earlier, be more aggressive in treating, and educate our patients on what this is and what dry eye is. And if we don't, we're doing a grave disservice to them going forward. So let me give you a perfect example. So when my daughters were teenagers, they had acne. And, you know, for them it was devastating. Oh my gosh, I can't go to school. And so all their friends said, Accutane, just get yourself on Accutane and, you know, this will make it go away. But I know what happens with patients that take Accutane is that it does destruction to the meibomian glands, and we've seen it. So I told them, no, we're not going to do Accutane, we're going to do intense pulse light. So the IPL took care of their acne, and we stopped them from taking the Accutane, and we saved their meibomian glands. Now, in that moment, they didn't realize that we were saving meibomian glands for when they were 30 or whatever. But guess what? 2 of the 3 daughters wound up getting dry eye disease. Now imagine, and we could control it with IPL, but imagine if we had put them on Accutane and we had some destruction of their meibomian glands, their dry eye would have been so much worse. So the things that we do for our patients today can resonate in the future. And so we have to be better at what we're doing and recognizing and treating these patients earlier.
So for eye care professionals, what are they looking for specifically when they look through the slit lamp?
Let's take it a step further before they look at the slit lamp. So one of the things that I do is, since this is a skin gland condition, is when I first walk into the room, I want to look at the condition of their skin. So you could tell a lot. 80% of patients who have rosacea have meibomian gland dysfunction. So when I walk in a room and I see a patient has signs of rosacea, I already know when I'm looking at their meibomian glands, I'm going to see telangiectasias. Are they taking care of their overall health? Do they look healthy? Does their skin look healthy? Do they have acne? Acne patients have meibomian gland dysfunction. Do they have aging skin, and have they been out in the sun too much so that their skin is aging? They're going to have meibomian gland dysfunction. So before we even get into the slit lamp, you want to sit there and get an overall gestalt of the patient and their skin. And then ask all the questions that we were talking about in terms of their lifestyle, their diet, their work environment, their home environment, all of that stuff. Then when you get to the slit lamp, the first thing that we want to do is look straight at their eye, right? Because that's what we're taught. But instead of looking at their eye, the first thing I look at is their lid margin. And then I push on their glands and see what secretions are coming out. Are any secretions coming out? Are they blocked? What do their eyelashes look like? Do they have a healthy eyelash, or are they losing eyelashes? Do they have bacterial signs or Demodex signs on their eyelashes? Do they have collarettes? Do they have scurf? Do they have sleeving? Do they have pouting of the hair follicle? Then look at the lower lids, then look at the upper lids, then look at both sides. So before I even get into looking at their eye and looking at their tear breakup time and looking for fat on their tear film, I'm looking at the glands, looking at the lashes. So that's different than what we're taught and what we see in residency or what we see in school, where we go straight to the eye and start looking at the eye and look at the iris, look at the cornea, look at the back of the eye. So slow down your exam, and take your time and figure out those things before we start jumping into looking at the eye.
So now you've looked through the slit lamp at the lid margins and the lashes, then what's next?
Yeah, so then you look at the ocular surface. So that could tell you a lot of different things. So I'm going to tell you some things that I know and some things that I'm working on. So here's things that I know, that patients with dry eye, that constant inflammation of the ocular surface starts to deteriorate the conjunctiva. So usually the conjunctiva sits on the sclera and it's, one tissue on top of the other. With long-standing inflammation, what happens is that conjunctiva starts to pull away from the sclera. And these patients are blinking on their conjunctiva, and that's one of the reasons why they're experiencing so much pain. So that's conjunctivasis. So that's one thing to look at. Then look at the conjunctival vessels. Are they dilated? A lot of patients, their main complaint with dry eye isn't the dryness, it's more the redness, and that comes from dilation of the conjunctiva vessels. Some things that I'm working on, one of the things that I'm noticing is you can tell overall body inflammation by looking at the episcleral vessels. So if patients have very dilated episcleral vessels, that tells me that they have systemic inflammation going on and that we have to treat some of that systemic inflammation to get that redness down. Then looking at the ocular surface, do they have any kind of, on the cornea, do they have any dry spots on the cornea? Is their tear film completely going over the cornea? One of the things that you'll see in patients that have had like an RK procedure, where they had something done to the cornea, is that kind of makes their cornea more like a tabletop. So instead of the tear film spreading on a globe, it kind of sits there on a tabletop and doesn't get to the corners. And then you can do kind of staining procedures, either fluorescein staining to see dry spots, to better see dry spots on the cornea, or lissamine green to see dry spots on the conjunctiva. So there's a lot you can see on the ocular surface, but I always tell doctors first go to the lid margin and then work your way over to the ocular surface. One of the things that we're doing is we have now technology that looks at video of their blinking, because I think, and again, these are when I have a theory, I'm going to tell you this is a theory that I'm working on, is that we're training our brains not to blink as much. So when we're doing all this screen work, we're concentrating and we're not blinking as much, but that starts getting into our brain and starts affecting our blinking pattern even when we're not working on the phone. And that's what I'm seeing, is that we have patients, a lot of patients, when you do video of their blinking, they have incomplete blinks, or they're not blinking at the right frequency, so they're actually making their evaporative dry eye worse. So one thing that the Japanese have been very good at is telling their workers to take breaks, block out the light, keep their eyes closed. And now I'm training my patients, if they're working on computers, or they have a job where, like my job, I'm a surgeon, so I'm on a surgical microscope and my eyes are wide open as I'm doing cataract surgery, to do some forced blinking. Make your meibomian glands work. And actually, when you do your cheek and using your cheek, you're not only bringing those lids together, but you're activating the trigeminal nerve to send nerve impulses to the glands to produce more of a tear. So there's so much. I mean, we could go on.
I could listen to you forever. So for an optometrist or an ophthalmologist who does pick up dry eye, I really see dry eye is similar to pregnancy. So you're either pregnant or you're not. You don't just have a little bit of dry eye. You either have dry eye disease or you don't. So when do you treat? When do you treat dry eye disease?
Yeah, so we want to get to the root cause of the dry eye. So we want to get those glands working better. Mm-hmm. So we could use drops that are anti-inflammatory. That may get the glands working better. We could do diet, but that takes a long time to work through to get the glands working better. But if you have abnormal working glands like the meibomian glands, which is 90% of the dry eye, we want to treat those meibomian glands to work better. And I've tried everything. Luckily, intense pulse light was something that I was doing 26 years ago. and discovered that intense pulse light could actually get the meibomian glands working better. 26 years ago, I didn't know why. It took years to really figure out all the mechanisms of action of why intense pulse light works. But if you really want to get the glands working better and get to the root cause of their problem, you're going to do intense pulse light early. Why wait? I mean, waiting on IPL to treat the meibomian glands is basically saying, okay, I'm just going to let inflammation and let this problem continue to fester and make the ocular surface worse. But now we know IPL does so many things. One, it helps the skin. So we know that IPL is used in aesthetics to stimulate fibroblasts to make collagen and elastin. We know that IPL closes off the telangiectasias that these patients have on the epidermis, and we now know that these abnormal blood vessels on the epidermis secrete inflammatory mediators that break down the skin and break down the glands. We know that intense pulse light decreases the inflammatory mediators that are made by the skin and made in your tear film. So we did the study showing that intense pulse light actually decreases the interleukins that cause inflammation to the eye. We also know that generating heat in the dermis actually stimulates heat shock proteins to make the cells work better. But the number one most important mechanism of action is that these wavelengths of light stimulate the cells of the meibomian glands to work better. This process is called photobiomodulation, and now we're seeing photobiomodulation used in all sorts of medical practices, whether it's orthopedics, aesthetics, retinology. It's being used. We're using wavelengths of light to stimulate the retina in patients that have macular degeneration. So we're using specific wavelengths of light in intense pulse light, and the wavelengths of light that we're using is red. We're using that 600 to 700 nanometer wavelength of light to stimulate the cells to work better, stimulate the mitochondria in these cells to work better. And that also goes with low-level light treatment. So intense pulse light is, here as a clinic treatment. It's 3 times the energy that we're using with low-level light. But low-level light is a nice home treatment that patients can use, and use our little patented technology at home with some red light and infrared to stimulate these glands to work better. So don't save it. Why are we attacking a problem by just attacking the symptoms of inflammation when we should be attacking the root cause, which is glands that aren't working better? One of the funniest stories I have is I have now patients that I've been doing IPL on for dry eye for over 20 years. And one is, he's a retired board member of a major company. And the board used to take pictures at the end of the year, every year. And every year he'd come in and go, look at how young I look compared to these old fogies. And so he sees that over the 20-something years that I've been doing IPL is that I've really saved his skin, and his skin's not aging. And if you look at his glands, he hasn't had dry eye problems since he started coming to me 20 years ago, which isn't the norm, right? What the norm is, the thought is, as you age, your cells are going to work less and things are going to be more of a problem. But if you intervene early, not only are you saving them then, but you're saving them much later. So everything that we're doing now is preventing more dry eye. Can you imagine if there was an IPL, what the percentage of dry eye patients would be? It'd be even more. And as we get older, we know our basal tear secretion goes down. So this could be a huge problem. So intervene earlier, be more aggressive earlier.
So for an eye care professional who doesn't have access to an IPL or the training that is required, what would you recommend, or when would you suggest they refer to dry eye solution?
Yeah, I don't think everybody should have an IPL. I think the people that do dry eye should want to do dry eye. I think it's its own separate specialty. I think that's going to be my goal here from now until I pass away, is working to make dry eye its own separate subspecialty, just like, retina, oculoplastics, all this, because there's so much into it. So, and you have to have the personality for dry eye disease. So I know some surgeons who are great surgeons, but they don't want to sit and talk to patients for an hour. That's just not their personality. They don't want to learn about the holistic way. They just want to get in there, do surgery, and go, and that's fine. So I don't think everybody should be doing dry eye. I think this is its own subspecialty. I think there should be dry eye specific clinics. So if you know you're not that person, you should be referring, and you find dry eye and you're not going to be treating these patients the way they should be treated, then you should refer. Just like when I see retina, I know retina from my residency, but when I see something that is beyond my scope and beyond what I'm going to be treating, I refer to our retina specialist. And I say, okay, well, this is something that you need to go see the retina specialist because you have a specific disease, and this is what they're specifically trained to treat. And they're going to give you the best treatment. So I would say, if you have a patient with dry eye disease and you know that they're going to need treatment, which is going to be everybody, you should be referring, unless you're ready to make this your specialty.
Well, as you know, at Dry Eye Solution, if any eye care professional refers to us, we automatically bulk bill the patient's assessment. So it makes it very easy for the patient to get access to the assessment, and we send a full report back to the referrer. So it's just a very seamless process.
Yeah, I think this is going to be another part of the paradigm shift, that dry eye is like, what used to happen is somebody, and look, this is a big problem in the surgery realm, is that there's patients who have dry eye disease that's not being diagnosed, and they're having surgery, ocular surgery, whether it's cataract surgery or refractive procedure or retina or glaucoma, and they're not doing very well with their surgery. Not because the surgeon did anything wrong, it's just that the surgeon didn't diagnose the dry eye. They have ocular surface disease and they're not healing well because the dry eye wasn't diagnosed and treated before they have the surgery. So what I tell everybody is that before you have any kind of ocular surgery, make sure you go through the diagnostics to see if you're a dry eye patient, get treated, and have a pristine ocular surface before you have any kind of ocular surgery. And so this is going to be another big paradigm shift, is that surgeons are going to realize that if they want to be the best, and most people want to be the best at what they do, that they're going to have to refer some of these patients to get treated before they have any kind of ocular surgery.
Well, it's really nice to see here, because that's already happening here. So some of the leading surgeons here are referring to us, and it's very amazing to see that shift happening already.
Their specialty, so I'm a cataract surgeon, I'm a smile refractive surgeon, and I can just tell you, if I don't treat their dry eye, I could be the best surgeon in the world, they're not going to have the best results. And that's going to reflect bad on them. So I think they're realizing what I realized a long time ago, is that the ocular surface is very important to have pristine before you do any kind of surgery.